Dr. Mickey Guiberteau, President of the American Board of Radiology, to present the ABR report.
Thank you, Kimberly. For over 80 years, the ABR has presented an update to its sponsoring organization, one of 5, original ones, now 8, on progress of what we have done for you, and some would say to you, over the last year. This year is going to be a little different because what I would like to address is the topic of MOC, Maintenance of Certification, which I know is of interest to you and to the substance of this meeting. It's no secret, and in the sense of the theme of this meeting, that we are in a period of unprecedented and profound change in our healthcare system, and that these changes challenge our long-standing dictums that we as radiologists know best how to certify our colleagues, how to conduct our practices for the best care of our patients, and how to value our services. And how we respond to these challenges now will affect our profession now and for the next several generations. For those organizations with missions in radiology, in terms of having quality missions, the responses have been unequivocal. Radiologists must now be accountable for mastering the competencies and meeting the safety and quality mandates of our time with meaningful changes in our programs. For the ACR, as you know, this means Imaging 3.0, Beyond Image Interpretation. For the ABR, this has meant maintenance of certification through a process of continuous certification. To maintain its value in today's environment, certification must be continuous and measure a broadened spectrum of competencies. This means career-long engagement in learning and professional development, assessment of knowledge currency on a schedule that's more frequent than once in a lifetime or once in a career, incorporation of competencies in quality and safety applicable to the healthcare system. So where do these competencies come from? We all know where they come from. They come from very powerful organizations in our society, in our culture, and in medicine. The IOM for patients and the healthcare system, ACGME and ABMS for trainees, and our own profession, ABIM and the Physician Charter, sponsored and signed onto by over 250 organizations for practicing physicians. Now, these competencies, which we are now expected to embrace, I hear people say that these are idealistic. Guess again. This is just one example. The new MIPS, Merit-Based Incentive Pay System, will have 4 physician performance targets, all in quality. And you might look at the third one, which is very familiar to you if you are in MOC, clinical practice improvement. I also hear from people saying, this is not pertinent to my patients. They don't care. Well, the ABR believes that patients do care, and these are not unrealistic. And even if you believe they don't care, the people who hire them and pay for their health care and their retirement and advocate for them do. This is a very powerful coalition. It can't be, these changes can no longer be ignored. So in response to this, in 2000, the ABMS established maintenance of certification with the AMA at the table. This is a structure of 4 parts, as most of you know: professional standing, lifelong learning and self-assessment, cognitive expertise, and practice quality improvement, all of which were meant to address the competencies by the organizations that I've just discussed. In turn, the ABMS allowed us, as the ABR, to establish a program of requirements for these goals. And for professional standing, it was a valid license. Diplomate Directed CME with emphasis on practice setting, Diplomate Specified Practice Profiled Examination, and Diplomate Guided efforts to enhance their practices and the care provided to their patients. And I've underlined Diplomate Directed, Specified, and Guided because the ABR program is one of the most flexible of all the boards in terms of allowing the diplomates to choose what they do. Unless you've been in a coma for the past 6 months, you are aware of what's happening at ABIM and in the internal medicine community. And I'd like to explain to you the differences in case there is some confusion between what the ABR is doing and what the ABIM did. As, for part one, licensure is the same. For part two, in terms of the ABIM, their diplomates needed to choose self-assessment modules that were dictated by the ABIM. In ABR, you're able to choose those. And in terms of self-assessment, we include all enduring AMA Category 1 CMEs, so we have a vast choice for you. For part three, the examination, ABIM had a specified examination that was, regardless of what your subspecialty was, you took an examination over the entire spectrum of internal medicine. In the ABR exam model, we allow you to choose what you want to be tested on. In terms of part four, probably the most controversial of these elements, in the ABIM, it was a complex point system that, frankly, I never understood, and many of their members didn't, which caused a great deal of confusion. But it, again, was ABIM specified content. In the ABR, the diplomate chooses the project they want, that they can design them themselves or choose from a variety of offerings from specialty societies. And finally, in terms of the process validation, the ABIM developed its program essentially in a vacuum. In the ABR process, we surveyed the diplomates, we talked to our professional organizations before designing this program. Now, not to be any surprise, the ABIM now considers the ABR to be a role model. And in addition, many of the reforms that they are instituting in their program are in the program that we already have. Now, does this mean the ABR program is perfect? No, it doesn't. And the ABR is going to use this opportunity of change and the ABMS understanding that each culture and each practice pattern for different specialties is different. And so we are taking advantage of this to make some improvements as well to a program we feel that's already reasonable. In terms of addressing these concerns, the NearUniversal Support, there is that for the goals of MOC and continuous certification in all our surveys and in all other boards. On the other hand, the requirements in fleshing these out to meet these goals has been a work in progress. And admittedly, it's been painful, not only for us as the ABR to get through these multiple changes as they occurred since the year 2000 and ultimately completed in 2006, and now we're a decade into it. And I know it's been painful for many of our diplomates to change their way of thinking and to really adapt to what we're asking you to do. As the MOC program has matured, however, and as the ABMS has become more flexible and encouraging of change, substantive improvements are now possible. So when and by whom are the MOC improvements made? Well, they're made by this group. Most of you think of the board as sort of some sort of disembodied ivory tower group barking orders to you from the ethos. In fact, we are not. We are 24 practicing radiology professionals, all of whom are in MOC, and most of whom are dedicated to their subspecialties and specialties in their practices. And they are working stiffs like the rest of you. They are having, each day they balance their clinical duties, their RVUs, with their external mandates, with their non-clinical activities, and with their family time. They are many days as overwhelmed with the demands on them as you are. So with this in mind, the board realizes that ABR MOC requirements must assure the public of a robust MOC program to support radiology's most widely accepted and empowering credential for delivering and advancing quality healthcare. But requirements must also be balanced with diplomate satisfaction and sense of accomplishment in performing an MOC program that is reasonable, and respectful of the busy and complex environments in which the diplomates practice. So how do we change these? What do we use for decision support in terms of doing this? The ABMS gives us the basic structure. Our 24 trustees bring their experience to the table, and we have 10 advisory committees. Several of those are on MOC in each discipline. We have 1,585 volunteers, mostly on our exam committees, but who do give us feedback for MOC. 8 sponsoring organizations, numerous subspecialty societies, and you, our diplomates, in our surveys, in our Q&A at various meetings, such as this one, throughout the country, year after year, and calls, letters, and emails that we get from you. So in terms of this decision-making, we've come up with principles. They're unwritten principles, but things that we believe should be incorporated into our MOC program. One is that a collaborative approach to MOC is the best approach. That is, we want your input. We want to avoid onerous burden to the diplomates. The diplomates should have flexibility to choose the content relative to their practices. The diplomates should earn credit seamlessly for what they already do. Examination should reflect what diplomates do. Attestation with random audits is sufficient for compliance. We don't want you to submit all of your MOC PQI data to us. If you say you've done it, we believe you. Unless you're audited, then of course we would like to see what you've done. And MOC fees should be reasonable. So how do we proceed from here? I want to talk about the fees first because that's really the easiest. The ABR annual fee is now $340. According to the Medscape survey of 2015, the radiologist's mean patient-related care income, if this is a real figure, is $351,000. Our fee is about 1/1,000th of what the mean radiologist salary is in the country. Now, whether you think this is a lot or whether you think this is a little, this does put it in some perspective. But this doesn't mean that ABR does not every year evaluate what we charge for this program. And I can tell you that every dollar of what you pay us goes back into our programs. None of our volunteers, none of our officers, none of us who work there besides our staff gets paid for any work that we do for the ABR. Now, what about the rest of the MOC program? Parts 1 and 2, these are basically resources that you already expend for your state licensure. So you're going to do those regardless of what we require. Parts 3 and 4 do require additional resources, so let's talk about those. Examination refinements that may be possible. ABR is continuing to evaluate the options to reduce exam travel time and expense. The question is asked, why do I have to go to Chicago and why do I have to go to Tucson to take my MOC examination? In our early surveys, we asked you, our diplomates, would you like the ABIM to take an examination after 10 years of practice in all areas of radiology, or would you like to tell us what you would like to take your exam in? Needless to say, the right choice was that you would like a modular exam where you could choose those. But we are a large specialty with many different subspecialties, so the modules are quite data rich. The local exam venues, such as Pearson VUE, had difficulty in managing all of this data with the technology they had at the time that we instituted these examinations. And after several small disasters, we decided to have our own exam centers where the environment in which you take the examination is more like you would have at work and would be standardized. We are in discussions with the local testing centers now to encourage them to update their technology for us. We're also exploring web-based testing in which you could take the exam at home or in your office. And we've worked as recently as last year with the ACR on some technologies that might be suitable for us. The ABMS MOC 2015 standards that were adopted in January say the following: exploring new methods of evaluating diplomate knowledge, judgment, and skills as alternatives to traditional testing is encouraged. This is new as of January, and I can tell you that the ABR is and will be evaluating these alternatives. What about part 4, everybody's favorite, practice quality improvement? In spite of a decade of vigorous education and template-rich projects provided by professional organizations, including this one, Part 4 PQI remains the most elusive and confounding component of MOC for some participants, and frankly, it's confounding to us too, of the board of the American Board of Radiology, the members. We struggle with this. In a recent Diplomate survey, which was conducted just several weeks ago, we had 4,000 responses out of 24,000 people, and those 4,000 responses came in very fast. And most of these came in the first 3 days. So we knew people were interested. This is the most response we've ever had this quickly in a survey. 75 to 85% of those people agreed that with the goals of MOC, not the requirement, and 70% were engaged or had engaged in a PQI project. However, a distinct majority of respondents were passionate, and I could tell you, very passionate, in asking for, if not polite, in asking for alternatives to PQI projects for fulfilling the Part 4 requirement. Now, I took this survey home with me and read it carefully, and it instantly reminded me of a cartoon that I've loved all my life, published in 1928 by Carl Rose in the New Yorker. And most of you may have seen this. It's a mother having dinner with her daughter who's sitting on her hands and balking about eating her spinach. The mother says, "It's PQI, dear." The daughter says, "You can read it for yourself." And so what's a mother to do? What's the ABR? You know, we are supposed to have your best interests as well as that of the public at heart. And so anyone with any sense would say, "Waiter, bring us a menu with more options." And that's exactly what we've done. And the options are now all around us. A decade ago, PQI made sense because we were really in our infancy in trying to deal with quality in our practices. And so it worked for us. Today, there are many more ways for you to really display your commitment and effort in quality improvement. And they're all around you, all of these. So at our May meeting, and with this survey in hand, the board decided that all of the things we had been working on before the ABMS spring, as I might call it, came about, that in our meeting several weeks ago, we decided it was time for us to act. So for its diplomates, the ABR now recognizes 2 categories of items by which to satisfy ABR MOC Part 4. The first, you all know about. It's our practice quality improvement projects, and we still believe those are the gold standard. But now we have participatory quality improvement activities. What are these? These are those activities in which a diplomate is actively engaged and which may be reasonably expected to contribute directly to or increase the likelihood of advancement or improvement of quality and/or safety in healthcare at the local or national level. So we created a menu for you. This is only a partial list, but I want to go through these. Participatory quality improvement activities include, and the key words here are active participation in, submitting data to a national data registry such as the ACR CT registry, or any of the registries as they come across. The Institutional Clinical Quality and Safety Review Committee participation, departmental or institutional peer review activity, departmental or institutional conferences on safety or quality, if you attend 10 of these a year, accreditation programs of ACR, ASTRO, and others, Local implementation of Image Gently, Image Wisely, Choose Wisely, or other similar campaign. Specialty-specific activity modules, especially organizational or institutional, those that your institution requires you to do. Why should you not get credit for that? Creation or participation in one of the elements of a local quality program, department dashboard, or daily management system. Peer-reviewed publication of a quality and/or safety improvement article. Completion of a survey of your peers or a survey of your patients. And completion of self-directed educational projects for physicists. Now again, this is not the complete list, but I wanted to give you an idea of how expansive we felt that your demonstration of efforts should be when you comply with Part 4. So now finally, I think a question that has arisen recently is, if you complete MOC, all of the things we ask you to do, even with the new improvements, what do you have? What is the evidence that MOC has value? Well, numerous studies link board certification with improved quality of care. I don't think anyone argues with that. And there is also strong evidence that physician skills decline over time and knowledge must be updated and refreshed. However, there is limited research to date on the impact of MOC on patient outcomes. We've only been doing this for nine or 10 years. And getting more and more people involved in this has also been an issue of getting enough data to make sense on this. Some studies in specific disease entity management do reveal an MOC outcome advantage. But these results cannot be generalized to physicians in other specialties or other diseases, particularly to radiologists, where we are only one part of an episode of care, and we do not actually manage the patients to determine the outcome. It is very difficult to prove value and quality for anything, particularly services such as healthcare. But does this mean that the lack of research providing a universal evidence base for MOC effectiveness means that it has no value? Does the fact that our ACR guidelines are now called parameters because they are not evidence-based indicate that they're of no value? I don't think so. Does the lack of evidence that the imaging we do can't be specifically linked to patient outcomes in many settings imply that they have no value? I don't think so. And evidence is in the eye of the beholder. I mean, collecting data on this, the data available now is being interpreted by multiple sides of the argument about MOC, and the same articles are quoted by both groups as being supportive of their point of view. So it's very confusing. And just look at the SFPSTF interpretation of the data on breast screening. And the MIPS quality measures, is there proof that these actually measure quality? We don't know that, but still they are a reality. So what we believe at the ABR is that continuous certification means that you have been judged by your peers to be meeting the standard of current competencies in your profession of radiology and are deemed capable of performing at a high level to deliver and improve the quality and value of patient care. And perhaps as much as evidence, the proof that MOC provides value is in the validation of competencies of radiologists, which create trust and a sense of value in our patients and those who pay for their care. This is my summary slide, and it's blank because it would be very difficult in the time I've been given to summarize all of this. So I'd like to just leave you with the following thoughts. Please be assured that the 24 members of the American Board of Radiology take our responsibilities for self-regulation of our specialty very seriously. This includes our duty to patients and the public, as well as our accountability to you, our diplomates, for making MOC a reasonable and valuable process. The ABR cannot be successful in its mission if we do not have the support and trust of our diplomates, you. And it is our obligation to earn that trust. Thank you very much.